Welcome back. In this video we're going to talk about glaucoma, which is an optic nerve disease. It's characterized by a triad of high intraocular pressure, cupped optic disc, and visual field defect. High intraocular pressure is caused by the imbalance of aqueous humor production and drainage, which causes gradual death of the optic nerve. Without that, it is called normal pressure glaucoma. And a high intraocular pressure with cupped optic disc but no visual field defect is called early or pre-perimetric glaucoma. The incidences of glaucoma increases with age, with 7% of over 75-year-olds having glaucoma. It is the third most common cause of blindness in the UK, and the risk of blindness is low if it was detected earlier. There are lots of other types of glaucoma, like congenital glaucoma, where the trabecular meshwork is not fully developed, and you can present with a ophthalmos because fluid is not being drained, so the eye is expanded and looks really large. Or it can be developmental, where it occurs before age 20. Pseudoexfoliation, where you get amyloid-like protein depositing and clogging up the trabecular meshwork. Pigment dispersion, where the iris rubs against the lens behind it and pigment cells rubbed off the iris starts to clog up the trabecular meshwork. Dubiosis, where there's new blood vessels developing all around the eye, including over the trabecular meshwork, in response to any ischemic conditions. Or angle recession, where severe trauma causes scarring of the trabecular meshwork, leading to lifelong high intraocular pressure and glaucoma. But what I would like to focus on today is on open angle and acute angle closure glaucoma. But just be aware that there are lots of other types, but treatment aim for all types of glaucoma is to lower the pressure. Open angle glaucoma is much more common. It is a physiological disorder, i.e. the anatomy is normal, but for unknown reasons, eye pressure is chronically elevated, causing optic nerve atrophy. It is a chronic and progressive disorder. Risk factors include Afro-Caribbean origin, family history, age over 40, hypertension, and diabetes. Patients present with painless progressive decrease in visual acuity. Loss of vision is usually in the peripheries because optic nerve damage causes progressive loss of visual fields. We can measure the eye pressure using the tonometry, and it will be elevated, i.e. above 10 to 22 mm of mercury. And under the slit lamp we can see optic nerve changes and optic nerve disc cupping or increase cup to disc ratio. Using gonioscopy or OCT, which is essentially a CT scan of the eye, we can examine the trabecular meshwork and the iridocorneal angle. It is important also to measure the corneal thickness because a thick cornea often gives falsely high intraocular pressure estimations. The mainstay of treatment is using eye drops. Beta blockers can decrease aqueous humor production at the ciliary body. Prostaglandin F2 alpha analogues can increase aqueous humor outflow. Adrenergics like bromonidine can decrease the synthesis of aqueous humor and increase outflow, and it also treats the erythema by causing vasoconstriction. Other things include carbonic anhydrase inhibitors and meiotic drops. These patients need regular follow-up because this is a progressive condition and patients often don't notice the symptoms. For severe cases, patients can have trabeculectomy, which is surgically making an artificial fistula between the anterior chamber through a hole in the iris and out under the conjunctiva, or microincision glaucoma surgery, or laser trabeculoplasty, which is opening up the trabecular meshwork. Unlike open angle glaucoma, acute angle closure glaucoma is an anatomical disorder where the iris is much closer to the cornea and blocks off the flow of aqueous humor through the pupil and back down to the trabecular meshwork. And so you get a rapid rise of eye pressure due to the iridocorneal angle being forced forward by the iris and the lens. It can be either enlargement of the lens, making this angle smaller, or the expansion of the iris muscle. Risk factors include being over 40, but most commonly being 60 plus. Family history of glaucoma. Drugs, for example, atropine-like drugs such as ipratropium, tricyclic antidepressants, selective serotonin reuptake inhibitors, topiramate, chlorpromazine, and general anesthetics, particularly in the elderly. Patients can often have no symptoms until there is a sudden pressure spike. When that occurs, patients will have a sudden onset, extremely painful and red eye, with nausea and vomiting, and blurring of vision. Patients often say that they can see halos of light around objects, for example in like car headlights or street lamps, and the pupil often will look not perfectly round, a bit sluggish and unresponsive and semi-dilated, and the eye is described as feeling very hard. Lying flat can often worsen the symptoms because of increased pressure, and the cornea can have a hazy appearance. Investigations are the same as open angle glaucoma. you'll examine the eye under the slit lamp and measure the pressure. Under the slit lamp, you may see that the cornea and the underlying iris are very close together. Cranioscopy may be featureless, or you cannot see the trabecular meshwork. And on OCT, which is a CT of the eye, it might show a narrow angle. The mainstay of treatment is surgery, and laser iridotomy is the one that makes a hole in the retina to allow fluid to escape to the trabecular meshwork. But in cases of acute, complete obstruction of the trabecular meshwork, where the iridocorneal angle is closed and there's a rapid rise in the intraocular pressure, admit this patient, give IV acetazolamide, which is antiemetic, IV mannitol, which is an osmotic agent that helps reduce osmotic stress before surgery. You can give all the eye drops that we normally give for open-angle glaucoma, such as timolol, omatoprost, which reduces pressure by increasing aqueous humor outflow, prednisolone drops, which would reduce inflammation and help constricting the pupil to increase the angle, which is also why we give topical pilocarpine drops, which is a parasympathetic mimetic and is a non-selective muscarinic receptor agonist to constrict the pupil and help open the outflow angle. And that's what either second line or when you're waiting for laser iridotomy or surgical drainage like a trabeculectomy. Lens removal, like a cataract surgery, is showing good results as well.